It is my great honor and pleasure to introduce our visiting Grand Round speaker today, Dr. Tony Shanks. Dr. Shanks is joining us from Indiana University, where he is the William H. and Sadie E. Coleman Professor of Obstetrics and Gynecology, the Vice Chair of Education, the MFM Fellowship Program Director, and most recently named the Director of Career Mentoring. Dr. Shanks began his training with medical school at Indiana University. He completed his OBGYN residency and MFM fellowship at WashU in St. Louis. And he joined faculty at WashU after the completion of his training, where he served as the associate program director and then program director of their residency, where I had the honor of completing my residency training under his leadership. In 2015, he moved back to his roots in Indiana, where he's been faculty since. He recently completed his master's in education in measurement, evaluation, statistics, and analysis. Dr. Shanks is a national leader in medical education and OBGYN and an expert in learning styles and the use of technology in teaching. Dr. Shanks is the recipient of numerous teaching awards and has both officially and unofficially mentored an endless list of trainees. In my personal experience, this is where Dr. Shanks shines. He's an approachable, fun, level-headed, and kind mentor who is full of words of wisdom, guidance, positivity, and encouragement. So I'm very grateful to have him as one of my lifelong mentors, colleague, and friend. Please join me in welcoming Dr. Shanks. I also failed to mention this code, ZUNZAZ. Zunzaz. Yeah.
Can everybody hear online? Someone moderating the chat? Give a thumbs up in the chat if you can hear us online. Excellent. Thank you so much for having me here in Madison. Thanks for that wonderful introduction. I know that when you guys send the codes, I'd asked if there was like a password to this, and my son, who's now in college, had passed this to his friends. So if my friends are listening to this on Zoom, I hope you're taking good notes. So there we go. So some disclosures. Dr. Rhodes, I knew her as Dr. Spain back in the day, mentioned my talk is going to cover some learning styles, and we're going to apply it to some technology and how we can integrate it, some of my favorite loves. So in terms of disclosures, I have no financial disclosures relevant to this talk. Sprinkled throughout, I'll show you some of my favorite books that I've picked up in the past few years. And if you're interested, there's going to be a QR code that will direct you to my favorite independent bookstore in Nashville, Tennessee called Parnassus. So if you're ever in the area, please check it out. The one thing I do want to disclose is that I use 3 of the VARC components to make this talk. If you don't know what that is, you will by the end. So who am I? I won't repeat the history that Dr. Rhodes, but I wanted to put down the timeline of when I went through my training, because I think it's relevant. I'm a proud member of Generation X, and I can distinctly remember a time in college. Here we are on a college campus. We didn't have cell phones. Like, cell phones weren't a thing. You would go out and hope you would run into people. And nowadays it's different. You have the world in your pocket all the time. And so I was in this transition period before cell phones and after cell phones, pre-internet, when you'd have to make sure someone's off the phone before you called somebody and got online. Little DVDs. I'll show you a DVD to the young people sometime that we had to put in a computer in order for us to get the internet. We've always had these technological advances that we've had to integrate. And the last part on here is, as Dr. Rhodes mentioned, I was always someone that, as a resident and a fellow, I would get great teaching evaluations from students, probably one from Janine, so thank you for that. And I was tabbed pretty early on in my career, you're going to be doing education. So I was actually the associate residency program director as a fellow, which I don't know if that's kosher these days, but when that was happening, Dr. Stuart Massid turned to me. If you know him, he's a gynonc and he's kind of a crusty old person. He leaned over and he goes, "What is your pedagogy?" And I said, "Dr. Massid, I don't even know what that word means." And so I thought it was important to kind of go on some self-discovery. So these are the objectives of the talk today, is I want us to set some foundational principles of learning, like what actually works. Now, there are courses, you can take degrees to do this, so to expect us to be experts, improbable, but I'll share a couple of my favorite ones. And then I'm going to show you how I use it with educational studies within OBGYN. The back half of this talk is part that really resonates with me, and my wife will tell you, like, you get me going on tech and everything. Like, this is what I really like to talk about. So I'll share about how we adapt some of these things, in particular, how we're using it in OBGYN, and then I'll close because I think we're standing on the precipice with artificial intelligence and large language models. What is this, and how can we actually leverage it? So I just came back from the AAMC meeting, if anyone got a chance to do this. This is Dr. Allison Whalen, who's in charge of everything. And the focus of this meeting, when it convenes medical colleges, is like, what's important? What should we be talking about? And AI filtered through it. AI filtered through it. I won't read the whole thing, but the last sentence really resonated. You know, we recognize this is rapidly evolving, requires openness to learning, grounding in values, and willingness to share. And that's literally what I'm going to do today, is I'm going to share like what I think are our values and share actually how we're employing this. So let's start with a typical labor and delivery. I have not toured yours, but I've been in many hospitals, and it probably looks like this. You have residents typing away on a computer, not interacting with other people as they're diligently doing their work. Medical students sitting at a table, often doing questions over time. And I always think, what are they doing? Like, there's so much things that are happening. And if I were to ask my students what they thought about labor and delivery, their reflections probably mirror the study that was presented at Tufts. Students feel ignored, they're in the way, they were not valued. And I think we find that ironic because labor and delivery is such an energetic place. There's a lot of chance for learning. So why are students not engaged? Like, how can we actually get students more engaged in the material? We got to think about them as an individual. So I start with this. So why are students quiet on a rotation? This is a great TED Talk from Susan Cain if you're interested in seeing it. There are 4 things, and I think the first one, the disinterest. Yeah, you may have a student that's not interested in labor and delivery or OBGYN. They may want to do something else. Us as educators try to engage them and make them see the things relevant. They're actually the people I really don't care as much about. It's those next 3, those introverts, the shyness, and the fear of embarrassment. Those are the quiet students that I really go out of my way to make feel comfortable. We use this term psychological safety. Like, what can we do to make our environments psychologically safe? So here's a little exercise that you guys can think about individually. We're not going to call in anybody, but there's an x-axis and a y-axis on this. And I want you to think about yourself as an educator. If you're with fellows, think about them. If you're with residents, and certainly residents, think about your medical students. When you invite them into your space, on the x-axis, do you make it warm? Like, do you welcome them? Do you get to know a little bit about them? Or do you keep professional distance? This is a job. You're here to just to follow me. And then think about what you task your student, resident, or fellow to do. Do you actively demand and give them things to do? Or are you a little bit more passive and say, just kind of follow it? And what we know is that the warm demander is where a lot of students benefit the most from, particularly first-generation students, students from upper represented in medicine categories. They would rather be quiet than risk giving an answer and being wrong. That imposter syndrome is very real. So what we try to stress is, let's make the environment warm. And once they feel comfortable, I can demand a lot of things. We can set really high expectations for our students. And again, how do you provide warmth? That first slide that I shared, that I had the picture, I didn't even acknowledge. So it said Indiana where it's from, but I grew up in Hawaii, which was the picture below. So I like to know personal journeys because it tells a story. And so I do that with my students when they're with me in clinic. That's always like the first couple questions. Tell me about yourself. What do I need to know? If you had 5 minutes to give me a talk on something that's not in medicine, what are you an expert in? And you'll get great answers. And they immediately feel more comfortable. And then you can have them do anything you want within reason on the clinical realm. Now, this concept of warm demanding comes from Zaretta Hammond. This is the first book that I'll share. So it's warmth, non-negotiable demand for student effort, and it's really mutual respect. And the basis for this warm demanding actually has its roots as a lot of the things that we'll talk about. If you go back with philosophers, so it's Aristotle. Merton kind of coined it for himself in the 60s, and it's about this self-fulfilling prophecy, that if you set high expectations for a learner and they're aware of it, they'll rise up to meet that. Conversely, if you set very low expectations, they'll do that too. So our goal as educators is psychological safety, number 1, make them feel welcome, and then you can actually give them a lot of roles. So we want to celebrate creative struggle, this comment of don't be afraid to fail. If you make an environment that students are afraid to speak up, they will not do this. And this Socratic method, when you're actually guiding someone to the answer rather than just kind of giving it to them, you want to see that struggle. Like that's actually how people are going to learn. Obviously, not just the students, with an LCME coming up, I'm definitely student focused too. Our visit is coming up next year, but we think about this psychological safety in terms of residents, but it extends to faculty. Like when we have M&Ms, when you have senior faculty being open to talk about their mistakes, like there's something very powerful in that. Now, how do you track success on how you are doing in your learning environment? We use something called the graduation questionnaire. And so I have to highlight, this is not all me, like this is a team that we do. So this is Dr. Marianne Chimhanda. Indiana University is the only medical school in the state. We're the largest medical school in the country. So Dr. Chimhanda runs the clerkship that extends not just in Indianapolis, but everywhere. And you can see our scores on the GQ. The blue line is the mean. And when we started doing this, we were at 67th percentile, pretty low. And then we've consistently gone up where students feel more comfortable in their learning environments. They've really liked their experience. But the question is, you may like something, but are you actually learning something? This is me pandering to the audience. This is Ron Dane, famous running back from Wisconsin, who tormented me during my college and medical school years. He was fantastic. His number was 33, which also was our average clerkship shelf exam on the OBGYN medical school clerkship. We have a goal, an expectation to be at the 50th percent. So how can we improve this? We have, again, such a large group of students that are coming through, all of them, learn in different ways when they have to give this material. How can we improve such a wide cohort of students beyond that 33%? So let's tackle a little bit about learning styles. You ever done like an online test, just to say like, this is how you learn? And there's so many ones, right? Our residents actually have in our labor and delivery a board. They do like these Enneagrams and they're these colors, and they have all the faculty and fellows grouped around these different colors. There's so many different learning styles. And actually we are all blends of different learning styles. And if you were to take these combinations, these learning styles will exceed the population. For you to expect to be able to teach to everyone's expected learning style is going to be difficult. It's big business. Like people make these learning tests. Business companies, there's a lot of, in the Harvard Business Review, they talk about learning styles when you're trying to teach your corporate entities how to learn something. And a lot of it is devoted to learning styles. Recently, if you were to track the Harvard Business Review, they'll say like, is this actually efficacious? Should we be targeting learning styles? So I mentioned the VARC, which is something that I think everyone, you may not know the term, but you're somewhat familiar with it. It stands for visual, auditory, reading, kinesthetic. Everyone has a preferred way of ingesting learning material. But the question is, does it actually matter? Does matching education to your preferred learning style lead to better outcomes? I could have pulled a lot of different studies on this. I will just kind of summarize this. We like to use the guinea pigs. When I say we, like cognitive psychologists like to use undergrads. They're readily available. So when you see studies, know that that's your target audience. They took 65 undergraduate students and they actually asked them, which of these do you think you learned the best way? And then they made them do an actual objective test to see which is the best way you would score. And then they made them do these experiments. So this top one is the kinesthetic test. You would feel these objects, and then you'd be asked to draw what you felt. The bottom one is the actual validated test of visual memory. You would stare at this object, and then I would take the object away, and you'd have to draw it from memory. And then certainly I could read you a passage and see how much you recalled. And what did they find? I picked this one slide on here. There's actually no correlation between what someone's preferred learning style and what they actually scored the highest in. And importantly, less than half actually knew what theirs was. Right? So I hear this all the time with the student. I'm like, you need to do this. I don't learn that way. I need to do that. And I always say, that's great. But just so you know, like, you should still ingest this material. And I almost liken it to like chicken, right? You may prefer fried chicken over grilled chicken. Me as an educator, I just care that you eat. So I don't try to match it up. So that's kind of the summary with learning styles is when you're dealing with large audiences, people are going to say this, but understand like it probably doesn't really matter, right? As long as they're ingesting the material. It makes more intuitive sense that what you're teaching matches up to the task. If you're teaching surgery, that's going to be a kinesthetic. You got to do simulations for that. But if it's something where you actually have to memorize things, when you're learning things from a textbook, that's going to be a different method, which I'll show in a second. So tailor it to the task. If I could go back in time when I met Dr. Janine Rhodes Dr. Spain at the time, as I'm starting my educational journey, if I could bring one book with me, it would be this book. And in this book, written actually by neuroscientists at WashU in St. Louis, they talk about 5 scientifically proven methods for actual learning. So reflection, generation, elaboration, interleaving, and retrieval practice. And we'll highlight a couple of them. So the first one is generation, right? You've heard this. We're not going to spoon feed you the answer. This is that productive struggle, right? So it's building off, we've created psychological safety. This idea of remembering something better is if you can actually struggle and pull it out. So we don't want to spoon feed. The top right or top left for you is a PlayStation controller. It has little icons, squares, circles, triangles, and I could tell you, which one's a jump and which one's a circle, but that's really not going to do anything until you push the button that you generate it and you learn and see what happens. So that Socratic method that's been around forever, there's actually some value in that because you're not giving you the answer, but you're leading the learner to it and they'll remember that better. The next concept is elaboration. And the medical students may know this better than seasoned educators, but you're attaching something something that's already exists in your head. You have a mental framework and then you're taking something new that you have to remember and putting it there. So mnemonics are one way. You can kind of rewrite something, put mappings. There's this concept called memory palaces, which you may not be familiar with. And this is this first book, Moonwalking with Einstein. And it's a story about a journalist who enters a memory championships. There's actually these championships where people have to memorize long strings of numbers. It's a thing. People do that. And he was really curious, like, how do people remember these things? And we as human beings, not as good at remembering lists of items as we are with space. Like you hear people say, I'm good with faces. I'm not as good with names. Like there's a reason for that. Like we can remember these spatial things. And so what a memory palace does is that think of like your walk this morning. So I was in the Union Hotel. I walked out to the car dropped me off at this room. I got in the front door and I walked down here. Now, if you gave me a list of 10 items to remember, I will take those items and spatially put them on my route. And I would actually make it really odd. The more odd that mental picture, the more I'm likely to remember it. So for the students that see that in the top right is sketchy, that's exactly what that is. They're taking something weird, putting it in a spatial place. And then when you have to recall some of these things, you remember that place and then you can build on that. The last one I'll show, some people were asking me about the water bottle, about how we use elaboration, is I used to carry around a water bottle on rounds, and we would always talk about magnesium. All right, so I'm an MFM by trade, and we're going to round on somebody, and someone's creatinine's 2. So what should we do with their magnesium? Do we normally dose them? Do we reduce the rate? And I would always point to the water bottle. So I don't know if you can see this for the people on Zoom, but there's like a little label on here, and there's a little screw top. And you can imagine if I screwed it off, things would drain. So I always say, when you give a bolus, you raise that magnesium serum level into that label, which sits between 4.8 and 8.4. It sits right there. If someone has a normal renal function, that's like me unscrewing the cap, in which case that's going to go down. So that's why we give them a rate to keep them in that middle. But if someone is, maybe I glued this on because their creatinine is 2, they're oliguric. What's going to happen is when I give that bolus, I put them in this normal range. But with every successive hour, if I don't decrease the rate or turn it off, I'm going to make them super therapeutic and have complications. I shared that antidote because I ran into a colleague a couple weekends ago at AAMC, and she and somebody else pointed out that they still talk about the water bottle technique because they know what a water bottle does, and we've elaborated and built on that previous example. So how can you apply these learning concepts to OBGYN, moving this focus back to our specialty? So I do a lot of ultrasound, and I like to play with toys, and so ultrasound simulation. This was a study that we did on medical students who have this anatomical knowledge, presumably from their first year. They know anatomy. They don't know how to do ultrasound, right? I want them to use this concept of elaborating based on their previous knowledge of anatomy, and we're going to make them generate and struggle. So I worked with a couple people to create 10 high-yield summaries that show up on the test. We powered this, and we really didn't need very many numbers, so we exceeded our sample size. And what did we find? Well, they scored well before and afterward. So we didn't, though it went up, it was not statistically significant in terms of our improvement. They all felt more confident in their skills, But more importantly, they all really loved it. And this really saved us during COVID. When students couldn't go into the clinical realm, we had the ability to simulate some clinical things. And so we never lost a step in terms of their education, which was great. Now, when I proposed doing something with ultrasound like this, doing anatomy and GYN things, initially there was some pushback, like, is this actually a target level for students? And I'm always like, let's raise the level. They'll rise to meet us. So don't be afraid to challenge your learners. All right, the last teaching philosophy, which is probably really important, is this concept of fluency versus mastery. I think back to when I was an undergrad and a medical student, probably more often. So like I'm married to one of my colleagues from medical school who brilliant, did really well in all their tests. So like if we were studying for a test, I was a reader. I would read it all the time. The joke in medical school was I should probably just buy highlighted paper and save highlighters, like, because I would highlight everything on there. And then when the test would come, she would always beat me. And I would ask, like, how did you study? Like, what are you doing? I just did questions. I hear that all the time. The rereaders always get blown out by people that just did questions. And that's because when you read, you create something called fluency. And fluency is not a substitute for mastery. The only way to prove you know something is to actually ask yourself questions. So this was a study that was actually big enough that it was published in the New York Times. They took our favorite guinea pigs, the undergraduate students, and they were going to study science and one of 4 different methods. So on the C, on the one on the right, they actually had them guess, what do you think would be the best way to do this? You know, the study, there were groups that were repeated study, people that tried that concept mapping, which is that elaboration, or if you're going to retrieval practice. So they were kind of all over, and everybody thought that repeated study was going to be the best. But as you can see, what actually does the best is retrieval practice. You actually have to ask yourself questions. I do this all the time because I do love to read. And sometimes I'll go through a couple pages. And I'm like, did I actually recall what I just read? And I force myself to ask questions to prove that point. Now, how can we apply this to OBGYN? So for the residents, you may hear this number. I know that there's been a change in the CREOG on how it's scored. You get percentages, but they used to give a number, like a 3-digit number that was tied to a percentage. And I always looked at this when I was a program director, as 200 was our goal that we would always try to get. And why is that? This was a study at 2 different institutions that if you scored 200 in your 4th year, so over that 60% mark, or twice in 2 years, you're going to pass your boards, which is what we care about, right? We're putting so much effort to train you. Can you pass your boards? If you never scored over a 200, you had a pretty high failure rate. So we wanted to keep track of our students, our residents' CREOG scores in order for them to pass their boards. So this concept of retrieval practice, we actually employed it in the residency. And we invested in something called TrueLearn, which is a question bank. This is Dr. Nikki Scott, our program director. She did this as her APCO project. And you can see from this slide on here, we gave residents free run of the TrueLearn question bank. They could sit there and do questions whenever they wanted. And then we actually had them do a mock CREOG before the exam. And what you can see from the scatter plot is that the more questions that somebody did, their higher year-to-year increase was. You expect to gain knowledge, you know, as you move from PGY 1 to PGY 2. So that's kind of the expectation. It's going to exceed it by using the question bank. This figure may show that a little bit better. We separated it out by the 3 years. The white stands for the previous year before we implemented TrueLearn. So in a given year, you know, year 1 to year 2, year 2 to year 3, 3 to 4, you would go up just that little bit on the white. For residents that go down a little, that's not uncommon. Like if you happen to score really well one year and you drop by a couple percentage points, not the goal, but it happens. But when we employed TrueLearn, we saw systematic improvements everywhere that it went up in every class. What about the clerkship? So we have embraced providing questions. And I told you at the onset, we started at 33%. And now we are kind of looked at as the clerkship model. Like everyone really likes it. The dean is certainly impressed by what we're doing. We have the highest clerkship score for our medical students at 62nd percentage. Because that first picture I showed you of the students sitting around doing questions, like we've actually embraced that. Like that's really good. What I do is engage them. What do you study? And then we can actually talk about it, but I don't make them feel bad for doing questions. All right, quick sip of coffee. This is good coffee, thank you. All right, so now we're going to transition to technology and learning, how we can bring things into the OBGYN environment. And as I mentioned, I came from a time when there was no cell phones. You just kind of show up and hope someone would follow you. The next picture is a handspring. This came around the time of the Palm Pilot. And actually, when I was a medical student, they gave us Palm Pilots and handsprings. and they didn't really know what they wanted us to do with it. They had a toy and it was kind of like, you figure it out. We also have streaming came around with Napster, and that was so great where like you could spend a night downloading one song. Fantastic. And then Nintendo came around, I think I was like 6th or 7th grade, and I actually designed a science project around Super Mario Brothers, where I told my science teacher, the more hours you devote to Super Mario Brothers, the better your hand-eye coordination is going to be. The study was super flawed because I did not have a control group. It was just me and my friends playing video games the whole time. I don't even remember the outcome, but every study I think of is some variation of that Nintendo study. Now we think about these tools that are a little bit more familiar with us. And now that you know the concept of VARC, you know, verbal, auditory, reading, kinesthetic, these are things that are all being employed for us. So how do we think about integrating this new technology? First off, like, why is this important? Like, why do we need to know how to use technology? You know, there's an analogy about people that used to make shoes, like the cobblestoners that used to make shoes. And when they were able to automate these things, they would have to teach someone how to automate the shoes. And there was a large population that became de-skilled. Their skills were no longer necessary. But there were also people that were upskilled, given this new technology, that became more important. So I like to think of technology as we are trying to be the upskillers and not be downskilled or de-skilled. If you look at this Venn diagram, which came out in academic medicine, if we think about our ancestors 200 years ago, if they were going to teach us how to be good OBGYNs, they knew the content. They knew that content. And it wasn't until this boom in the 60s and 70s when we learned about philosophy and how people learn, cognitive psychologists, that we thought about this pedagogical knowledge. Like, we're not going to teach to someone's learning styles. We're going to tailor it to the task that we're given. But now there's this new area called technological knowledge where we have to be able to integrate these new tools thoughtfully. I would also advocate that there probably should be a 4th circle about political determinants of health, because we have to think about that in our field as well. But for today, we're going to sit in that center between content knowledge, pedagogical knowledge, and technological knowledge. So comfort with new technology. As I'm looking at the audience, I can't see the people on the Zoom, there's this concept of a diffusion of an innovation model. When something new comes along, where do you sit? Right? So on one side, you have the innovators. And again, a talk like this is always difficult because the audience reflects this. There are going to be people that hear what I'm saying and be like, I did this 6 months ago. This is, not worth it. And then there are people that are going to hear this, be like, I'm not ready. And we have to recognize that our goal is just to kind of rise everyone up, but be aware of the individual differences. So the innovators are the people that are creating these things, the new things that come along, the Steve Jobs, the Bill Gates. Then you sit with the early adopters, and that's probably where I sit. I see the toys. I don't make the toys, but I play with the toys pretty early. And it's my job to kind of bring everybody else. And then we certainly have laggards that are not going to change unless you force them to. I found this picture online as a proof of my early adopter. So we had a resident at WashU whose husband worked for the Post Dispatch and knew how much I liked toys. And so they came over to our house to show how we were using iPads. iPhone came out in 2007, iPad came out in 2010. This picture was taken in 2011 with my young kids. And we used the iPads for everything. So you can see we played games, we read, and it's just kind of an ironic feature that I was living in St. Louis at the time, watching IU and the Pacers in the background. So I had always been big on adapting these new things. All right, so I took on this toy, but what else were people using when new things come along? So the iPad, everyone's familiar with the iPad. So a medical school in California actually bought all their medical students iPads, and they pre-branded it with a lot of apps. They put things on there that they thought people would want to use, handbooks, the wheel, and then they gave them a survey on like how they thought the students liked it. And what I find ironic when they published this is, it's been almost 10 years, and these concerns probably are still relevant today. Wi-Fi issues, things crashing, the perception of attending physicians not thinking you're doing work. Like, that's a bias we have to think about, that students are going to be more facile at using technology than we are. And that maybe it's not just cutting corners, that they're actually doing things the right way. All right, so what are the issues when we bring on adapting new technology? Well, number one, who's going to pay for it? That makes sense. And if you introduce something new, like, how do you train people on how to do it when that doesn't really exist? Again, you have the people that don't want it to change. And then, yes, we're making things more convenient, but are we lacking that critical thinking? Now, I think this is a big issue with a lot of these tech devices, is the distraction, the weapons of mass distraction. So these are some of the apps that can distract you from your task when you have a smartphone that's not a single-use device. There are going to things that are knock you off your task. So just a quick aside about the importance of distractions or negating distractions. This is one of my favorite studies that I love to point out to residents. So they actually took students, all right? They're going to study the impact of distractions. They take students, they're going to ask them a short passage, and then they're going to ask them to recall what they remembered. And there were 3 groups. 1/3 of them, they're not going to be interrupted. They're just going to read and be tested. Now, the other 2 groups, they had like these pagers and they were going to be interrupted. So the middle group they were actually interrupted 2 to 3 times during the study. The other group that had the pagers were not interrupted. They just thought they were going to be interrupted. So they were on what they call high alert. And what they found is if you're on high alert, that's just as bad as if you're getting disrupted. Like getting knocked off tasks are important. This is a very simple schema of why it's so important to minimize these distractions. Because as I'm giving information, that's what's called the intrinsic load, right? Now, you now know the concept of elaboration. You have things that you're trying to integrate. That's the germane load. You're linking this thing together. And it behooves us to minimize the extraneous load. So do the best you can to avoid distractions. Like if you all find yourself distracted by your phone, you can change the settings on your mail app or your messages so it doesn't come all the time. Try to avoid, when you're not on call looking at it, because it definitely knocks you off task and you're less successful to get back into that flow status. Now, thinking about us as educators, there's a couple tools that we use, and I want to bring this up on how we can do a little bit better job. And this is one of my favorite theories called the dual channel theory that pertains to multimedia. It's a big word. This is a complicated slide, but you've all done it. You've all been in rooms and heard PowerPoints or maybe watched YouTube videos that are doing it. So what is the concept of this? Is that when you are watching a video or a PowerPoint, I can throw anything I want. I could speak faster. I could speak in a different language. I can show more pictures and animations if I wanted to. But ideally, I would try to time these and kind of get them to go at the same time, because you also have your own long-term memory. And that's kind of the unlimited part, right? And the part where working happens, that germane load, is when you're linking these things together. So you want to time things because your working memory is limited. And so you create a bottleneck when I give information too fast. So this is when we do these exercises. We have an education day at IU for residents, and we teach residents how to give PowerPoint presentations in terms of minimizing pictures. This is the slides that I show to talk about this cognitive load. Minimize distractors on the screen, try to time what you're saying with what you're showing. Now, I want to go back to the forced compliance with technology. And if you were like any other place, it was Zoom, right? When the pandemic happened, we couldn't be in rooms like this. We had to go virtually, and no one really told us how to do it. Just have at it. And I think at first we all thought it was great. We didn't have to travel nearly as far. We can still do what we wanted to do. But it quickly became a burden. So why is this Zoom fatigue real, right? You're at a close distance staring at stuff. That cognitive load that I just mentioned, there's like so much input that's coming in. What are you looking at the screen, right? It's just all day mirror. Like watching my daughter do Zoom classes when they were in high school, like she just stared at herself the whole time. And then the reduced mobility is certainly a big thing. Like Zoom fatigue is real. And one of the best things I feel is when I get a Zoom meeting canceled, like an hour beforehand. It's great. Now think about it from a presenter standpoint, right? So in the picture, no one does Wordle anymore, but there was a time when we all did. And so that's what it looks like to a presenter, just black screens, and you're speaking into a void. We actually did a study with some friends across the country, and we asked responders in the age of virtual grand rounds, what did you think about this? And I'm not calling out the people that are on Zoom because I do this too, but you're more likely to multitask when you're not in the room. And then 69% of people felt worse with Zoom grand rounds. So while I understand it, and certainly we have regional sites that we go to in many hospitals, and it is impossible to get everybody together in the same room, it's presence. Like presence matters. It's why I came to visit you, because I wanted to be in this room and share this with you. So think about things. If you can be there with somebody, be there, because it matters. Now, how can we do that in terms of delivering content? Just a quick aside about something called Nearpod, which was told to me by my former program director, and it still exists today. It was championed by elementary school teachers. You can easily upload your PowerPoints, and then it makes things very easy for you to ask questions and for people to respond. So for example, in the top right picture, I've got a maximum vertical pocket, bless you, maximum vertical pocket. So if I'm giving a lecture to students, if we're in the room and I say, someone come to the screen and draw it, you're going to have people that won't want to go up there. As much as I preach the concept of warm demanding, I've created a space where no one's going to want to jump forward. But with Nearpod, everyone can sit at their tables and draw on their own. And I can still see everyone's responses. Everyone step forward to try something, but no one has that fear of embarrassment. We've actually done games. This is one of our fellows, Dr. Ali Dejan Miller, who's now at Vanderbilt. And you can see how much fun she's having because it builds on competition. So I love to use these little tools. Jeopardy Labs is another good one. People love questions, and questions work on how you remember things. So let's make these things easier on ourselves as educators. Nearpod, Jeopardy Labs. And again, as educators, prove what you do. If you're doing something, you should probably share it with other people. So we did this with actual physical assistant students. This was lectures I used to give to them. And we tried this with Nearpod versus, the flipped model and a hybrid. So flipped is where you give people the stuff ahead of time and then you go over these cases together, and everyone loved the Nearpod. So very popular. What I will not belabor on too much are virtual reality and something called augmented reality, but I want to make people aware of the difference between the two. There is a great book written by, I didn't put the QR code in here. It's a little bit outdated, but it was from one of the educational officers of Apple. And he talked about this coming technology as they were investing in things like the Vision Pro, where is virtual reality or augmented reality what we're going to go to? And he actually thinks it's the latter, more augmented reality. Virtual reality is where you wear goggles and you are in a simulated environment. You're kind of closed off, and that word presence, you're losing a little bit of that unless it's completely immersive. I feel like simulation in that aspect will be beneficial when you're bridging people from far away. Maybe you have someone on one edge of Wisconsin and someone here, and you can do a simulated patient that I think about it with IU, with our regional campus models, that we can do OB simulations now with these goggles. But having gone to the AAMC, that's a little bit farther away. And more people are investing times with things like augmented reality, where you have goggles or headsets and you still see the real world, but it's just overlaid with data. This is a great book by one of the co-founders of Warby Parker, who actually, if you were going to try to do your own augmented reality and you wanted to do it well, that 85 to 15% concept. Like 85% needs to be the real world, keep it on the periphery, 15%. I'm telling you this so if you ever get a chance to read articles and you see these pictures, did they maintain that 85 to 15? And it makes sense. You want to minimize clutter, an intuitive user interface. You may be familiar with the Meta glasses from Ray-Ban, and everyone is getting me super jazzed on that. And then I remember, do you not remember the Snapchat goggles? Those still exist. They sit in my desk drawer. No one uses that. So these two technologies exist, but people aren't really using them that well. But there is one technology that is here and people are using. And this is my last part that I'll talk to you about, which is artificial intelligence. You get a chance to meet me. I had a fun time with the fellows last night, but I love pop culture, so you're going to be able to answer this. The first time artificial intelligence was featured in a movie was in 1927 with the movie Metropolis. It's been featured in some benign versions and some maybe apocalyptic versions that are on there. And artificial intelligence, you're just simulating intelligence, but it's done by machines. If you were to do a PubMed search on the use of artificial intelligence in medical education, this is what your grid would look like. We're thinking about the 80s, there's not a lot there. And then an explosion that continues to rise with thousands of studies in there just last year alone. Now we've been here before, right? This came out in 2020 about a hype cycle of something where we get really interested in something and then there's a little bit of retraction, a little bit of excitement and retraction. Eventually we're going to hit the point where things are just going to take off. Ironically, a lot of these AI explosions seem to be timed when a computer beats somebody in a game, be it chess or something called Go, which I've never met a human that actually plays Go, but they love to test computers on it. So eventually these computers are going to take off, and I don't know how you feel, but it feels like we're getting close where things are really going to take off. So these are some terms. Not everyone is as familiar, and I apologize to those that know this really well, but where do the things we use sit in this big circle? So as I mentioned, artificial intelligence is just a general catch-all term for things that are done by machines that can typically be done by humans. The subset of that is machine learning, where you can make predictive patterns based on things that you've seen before. Within that, deep learning, start doing these things on its own, and then generative AI is when it's making these things for you. The things that we use things like ChatGPT and Copilot are called large language models that sits deep in the center, building on all these other things that come before. So the power of prediction. I showed you this slide earlier from Dr. Nikki Scott's study, where the more questions you did, the higher your increase on a year-to-year basis was for your CREOGs. Two variables, I can make a best fit line, and I can predict the next person that does 1,000 questions, where I think they're going to be. 2 points, right? 2 points, 2 dimensions, that's great. What if you had 1 billion points and you had a lot of different vectors? Well, that's really the concept of neural networks, is that you're getting more variables. There's more information out there to create these algorithms that are going to predict what you want. So this picture comes from the 1999 movie, The Matrix. I'm going to spoil that movie if you've not seen it. So there's this part at the end of the movie where Neo, played by Keanu Reeves, is in a hallway, and he's got Mr. Smith staring at him with these agents, and he looks at him like real people. But there is a moment where it turns into these green numbers and symbols where it's code. And he realizes there's just pattern in the data. And that is what these things do. When we're talking about generative AI, making things with pictures, or when you're having text conversations with things like ChatGPT, it is built on patterns of words and data that have created vectors. And so when you are inputting something, it actually will tell you that based on how it's read these texts. Now, again, I sit with colleagues and we use these tools, and I certainly use it more than them. And these words like, what does GPT actually mean? All right, so GPT, and OpenAI did us a favor by putting it in the title. So we all kind of know what it is. G stands for generative, right? It is making things for us. When you've started your texting on your iPhone and it always gives you the next word, like that's generating text for you. So that's the generative. Pre-trained mean that it's read all the books. It's read more books than all of us in this room put together. It has scoured the internet that it has access to. It is pre-trained on that material. And then the last part, the transformer, I think the easiest way to understand it is that it speaks to you in a human language that you can understand, right? So it's making things up based on what it's learned in a way that we can understand. When ChatGPT came out, in the fall of 2022, my son was a junior in high school, and I shared this anecdote last night, and I was blown away. I was like, I'm going to use it. And this is me typing it in. I was like, ChatGPT, tell me about yourself. Like, what are you good at, right? I'm a large language model, type of, learning algorithm called a transformer. I can design text. There's a counterpart called Dolly, where you can ask it questions. This is me asking it to make an abstract picture of a computer explaining to a human what ChatGPT is. And I found it ironic with my son studying anatomy. He found a lot of issues with it, and he and his friends stopped doing it because studying anatomy, it was giving him wrong answers. This was back in 2022. Now things have changed. This is my same prompt in the 2024 version where I ask abstract painting. You can see the resolution is getting better. And I would say that not just in imaging, but also in your text prompts that you're getting. So if you've not used ChatGPT, this is what it looks like. Simple text box that we're familiar with on the bottom where you can write a question. So for me, I asked it, does teaching to someone's perceived best learning style improve medical student education? And it gave me the answer, which I knew was right, that you don't have to read the whole thing, but it says that's just kind of been disproven a little bit. But I think this shows the concept is I had done the work and the research ahead of time so that when I put in an answer, I knew what it was giving me was authentic and not fabricated. And I think that's the challenge as we're integrating these new technologies is what's real and what's not real and what is important for someone to learn. Now, I kept this picture and I could update it with what ChatGPT was using, but this is a good reminder that when it first came out in 2022, in early 2023, so now over a year ago, what were people using it for? You can create outlines, lesson plans. Everyone really liked to do questions with it. So they were asking it to generate questions. This is actually something that I do now. I mentioned Jeopardy. If I have like topics, I'll just ask it to give me some questions and then I'll refine them. We as educators have to come up with guardrails and what we think can and cannot be used. And why the guardrails are important is this example. I asked ChatGPT to write me an article and provide references for AI implementation in medical education. And it gave me a very reasonable few paragraphs. It made sense. And then it provided me these references. And when I went to look at them, they were all fabricated. Like none of them existed. They're all fake. And it's gotten better where some of these things, they look real, but it's up to you to change it. So what are the issues with large language models? So the one that we worry about is bias. And unfortunately, we live in a world that's rife with discrepancies and bias within there. So when you train a model on something that's biased, you're likely going to get biased results. We hear all the time about images also being created. Doctors are always white men, less women, Black physicians. So be cognizant of that. Security is an issue because these things that we're using, we don't know actually what they're doing with our data. It's kind of a bargain that we're accepting. There was an article in AJOG where they said, if you're worried about someone using ChatGPT to write something, maybe like personal statements, they actually have filters, but you can imagine these things change all the time. And I've used this to run things through when I'm worried about what someone's writing. Now, which LLM should you use? I don't know if anyone has a preference here in this room. These are the different icons, which to me, they all look kind of similar in what you're getting. And when I think if I'm going to adapt an LLM, it depends on the use case, what I want it to do, but I certainly want it to be accurate. I want it to be specific to what I'm asking. I don't want it to lie, which is confabulations. And ideally, you would provide references. So I'm so proud of one of our residents that took on this energy that I was interested in and actually did a study between these different large language models over the summer. She took on Alpha ACOG, they have these patient frequently asked questions that you would give to patients on different conditions. We asked those same questions into these large language models, and we de-identified them so that these experts at our institution didn't know where they were coming from and asked them to rate in these. Copilot, which is a Microsoft product, which actually is ChatGPT 4 now, objectively scored the highest on all the things that we wanted it to do. But ironically, when we asked them which one they actually liked, they preferred ACOG and ChatGPT because of that transformer part. It talked to them more like a human. And again, like the pace of this is moving so fast that if I were to do this same study now, I would probably get different answers. So how can we adapt LLMs in the current climate into what we do with OBGYN? This was a systematic review that came out over the summer that kind of looked at what are people using these things for, right? We hear ChatGPT, but what are people actually doing? And the majority are using it to answer questions. And people are surprised that it does so well. I'm not surprised. It knows more than I do. Like it has all that information. It should be able to answer it. But what other things can we use it for? So I'm going to share with you here at the end what I use it for. When Dobbs came out in Indiana, it created certainly an uproar, which I'm sure at many other states. And as Dr. Rose mentioned, I work with the medical students. And so we actually designed a study asking our students, were you more likely to stay in Indiana or a state with restrictive abortion bans? So predictably, you can find out they're less likely to stay there. But I gave them a chance to write free text comments at the end. And I'm telling you, it was raw, it was de-identified, and students were as honest as they could be, and it was really hard. But I needed a way to kind of get these answers together so that we could publish this. And so we did a thematic analysis. I de-identified names, and I input this in there, and I asked it, group these 150 comments into themes with representative quotes, and it did. I went back and looked. I agreed with the themes that it created, but I also went back and proved that it did not fabricate any quotes, and it did not. So it is imperative that if you're going to use tools like that, you still have to double check because you are still at risk of confabulations, and certainly check with the journal. Journals have gotten better. There are now journals dedicated to using this in medicine, but that's one way that we used it. The second way is very easy. You know, ChatGPT 4 is a Microsoft product. This is a Gantt chart. So someone asked me if I would help them write a grant, and they needed a Gantt chart on what we're doing in a given month. This took me just a couple minutes. I provided the dates, what I wanted it to do, and it spit out a chart. Things were out of order, and I refined it, but this is the output. Something that would have taken me a lot longer, it was able to do on its own. Now, the last one is probably I have two projects that I'm probably going to do, but this is definitely one of them that my colleagues like the most. You don't have to read these words, and that's actually the point. This is a typical email I get once a week from my labor and delivery, chief. She's one of my MFM colleagues, and she's like, this is our new protocol on who gets drug screened when they come into labor and delivery. It's literally this, a bunch of words, and I keep it in a folder. And so if a patient comes in where I think meets this criteria, I'm going to have to remember where that folder is, find this, and then I'm going to actually have to read it. That seems highly inefficient, especially when I start building on multiple ones. As an aside, I don't know if you've ever used the WashU manual. That's an app. You know, it used to be in a PDF form. We created these protocols in St. Louis. And so Ken and Omertag and myself wanted to make it into an app for the iOS store. We went and pitched this to WashU undergrads, and it became someone's semester project that they condensed these PDFs into a usable app, a semester. So kind of analogous, right? Now we're a little bit further in time. I want to make this something that's a little bit easier. So I put this into Copilot, which uses ChatGPT 4, and I say, I want to make an app based on this, because this is too complicated. It needs to be easier. You're going to hear these things can create code. What does that mean? This is what it means. It can take my prompts and convert it into code, which I then, there's one step on here, which is very easy as cutting and pasting. And now I've created this. That same document looks like this, that can sit on a desk, and it is now a series of prompts that go yes, no, yes, no. You click the patient, this can be done by the MA or the nurse, and it tells you what to do. Different patient comes along, maybe it's different, yes, no, which one you want to do. And then it tells you exactly what to do. And so these documents are very important, the content, but now we think about the context, where to find it. I think that it has a lot of power making things easier for us. All right, so the next steps for LLMs, this is the most recent book. If you're interested in seeing on how to adapt these things, I encourage you to check this one out. You're going to hear this term, or retrieval augmented augmentation. So when I said that these things are pre-trained, that means they're done, they're finished product, but you can still fine tune things for your own devices and uses. If we wanted to do something for MFM, we can upload our own documents. If we want to do something for education, we can do. So if you're ever meeting with a coder, don't say you're retraining the LLM. They get really upset, as I learned. You are actually going to be fine tuning things. Where is this headed? Precision medical education. Personalized education. We now know when students come through, we have data points on how they're performing. We can now tailor things to them. We can use tutors. I myself, as Dr. Rhodes mentioned, I did a MESA, a Master's of Education with some high-level math. I actually use ChatGPT to help explain concepts to do it. So very helpful for that. And lastly, are recommender engines. If you've been on Netflix and it always tells you this is what you should watch next, that can come in the realm of education. Based on your performance, it'll make suggestions. So I think that's what's coming. So in summary, we've covered a lot, some foundational principles of learning. I gave some use examples on how we do that in OB, and then talked about technology as well as LLMs. So I want to thank you. I still am on the fire heap called Twitter. I don't know for how much longer, but that's how I am. That's my email. So thank you so much. Can I do it in time? Okay, good.
2 minutes if anyone has a quick question for Dr. Shanks.
Turn right onto Timber Lane.
There's a couple in the room.
Yep, go ahead, Dr. Pogba.
So that makes it even more special to me. One thing that I struggle with, I agree with you about inviting students to participate, the question answer method, that is the best way to learn. It's the same as taking a test when you ask a question and elicit an answer. But it's a fine line between pimping and getting somebody or inviting somebody warmly into the space. And how one perceives, a student perceives that is also individual. What is your technique? Personalities you can do nothing about. My kids.
Turn right onto Timber Lane.
So, but apart from that, what can one do to warmly invite students and learners to participate and know that what happens in Vegas remains in Vegas?
Yeah, and I think that the timing of those words, warm, demanding, are important. You've got to make the environment warm before you start doing the demanding and the question answering. And I can tell you from my evaluations, when I look back on what students have thought of how I've done it, they've specifically mentioned that I say, where did you do undergrad? Where did you grow up? Tell me one interesting thing about you that makes you unique. They will cite that as reasons that they felt comfortable, that just asking something about themselves made them feel that I cared enough. And then I do challenge my students quite a bit. Like I make them do it, but I always say, like, you are not a finished product. I do not expect you to know all the answers, but I do expect you to try. Yep. Thank you. There's another question in the room.
Thank you so much.
I'm sorry, go ahead.
My question is, you showed a plot that showed that there was a correlation between doing more questions and getting doing well on your ABOG boards, written boards. But do we have study, because that's certainly one piece of it, but do we have studies that show doing more questions makes you a better clinical provider? That I can have a student sit and do 100 questions, and that's the same impact as them reading and then seeing a patient.
I think there's a lot in the literature about the impact of questions. And the more questions you do, that's a great way to recall. But if I'm reading your question correctly, does that actually make you a good doctor?
Yeah.
Because there's other things to that. And that is to be determined. You know, like, I think we all certainly know people that do really well on exams that may not be the best doctors.
Right.
Conversely, people that maybe struggle with exams are the most warm and compassionate. And there's room for that too. I take this as a way to build those people up, that people that I know are going to be fantastic physicians, but maybe I'm a little concerned on how they're doing on CREOGs and what we can do. I would say this is the proven way for you to improve it. So that way you can actually pass boards and serve patients, which you're going to be great at.
Thank you.
All right. We are at our time. Thank you guys so much for coming.
Thank you so
Dr.
much.
Shanks.